Hi again, it's BJ Miller, Palliative Care Doc, with some follow-up questions from our webinar on communication today.
Okay, this one is a little bit long, so I'll read the whole thing. I have a question that I've been struggling with for several years now. I'm an ALS patient, and my husband of many years is my caregiver. He's an amazing and kind man and would do anything for me except communicate. I know he's terrified about what lies ahead for us, but keeps everything bottled up. We've tried counseling with palliative care, but he eventually stopped with no explanation. I can easily share with friends, but I feel lonely in our relationship. Any tips for how to break through?
Hmm. Thanks for that question. It's hard. I know your story reminds me of some of the families I've been working with recently. It's not an uncommon scenario. Um, so one sort of general way forward maybe sometimes is often enough works is if you said, honey, again, just so much like you just prefaced the question to us. Honey, I love you so much. You are so good to me, and you're so kind, and thank you, and it means the world to me. And as we go down this road, it would be, I'm missing, I need to hear from you. I'm missing you. I know there's things happening in you that aren't being expressed, and feel them, but I don't understand them, and I need you to help. I need you to talk to me. If you can't do it for yourself, please consider doing it for me. It would mean so much to me. We don't have all the time in the world. I don't want to have regrets. I love you so much. Whatever's in you, I want to hear it. I can handle it. Something like that. Put it on you. Like he may feel, maybe he thinks it's selfish to talk about himself. Maybe he can't find the words. Maybe he's afraid he'll hurt your feelings or who knows what. But sort of framing that all around love, appreciating him as a person, and asking him for your sake. Tell me, I need to know. I want to know. Not only is it okay for you to tell me what you need, but I want to know. Please tell me. You're doing me a favor. Putting it on yourself. A lot of us, in the name of love, can respond to the request of someone we care about much more than are left to our own devices. So that kind of give that a try. And it may take several conversations. Sometimes people will sort of crack a window. So after you've set that table, at some point, maybe he'll respond. Maybe he'll throw out a little test balloon. He'll say something like, "Oh, I was pretty bummed out this morning," or I don't know what. He might just crack a window open a little bit and sort of throw out a little test balloon about how he's feeling. And so you're going to want to listen for that and make sure to respond because, he might be able to stick his toe in the water and then a second toe and a third toe in this way. So listen, and it's back. Once you've said your piece and framed this, then it's really on you to listen well. And also, if you see that you can tell he's bottled up, you can tell something's bothering him in real time, simply say, honey, I think something's going on in there. I can see you. Come sit with me. Come talk, close the door. Let's talk. That kind of thing. So a part of it is saying what you need and setting the table like we're talking about, but part of it is listening really tenderly and exquisitely and letting these little trial runs happen. Maybe he can talk about himself or his own questions for a few minutes and then he'll get uncomfortable and close the door. That's okay. You can just say, hey, I appreciate talking that much, and then try again a few days later. And you can inch our way forward a little bit.
Okay, great. The next two questions are a little more on the clinical palliative care side, so we're switching gears a little bit, but they both came up during our discussion, so I want to make sure they're addressed. The
Mm-hmm.
first one, I'll just read this out. I am a first-year medical student, and I am interested to know your views on the future of the doctor-patient relationship. Is it realistic that every specialty will evolve into encompassing the philosophy behind palliative medicine? Is there anything we can do now to help with this process?
Wonderful question. So my bias would be, in my mind, all healthcare should be palliative care. The idea that we honor our patients and their families' points of view, the idea that we defer to their points of view, that this is a subjective experience, and that ultimately our work as clinicians, as doctors, has to serve the person, has to serve the patient, and has to be on and towards the end of making their life better and suffering less. So I just described palliative care, and in my mind, all of healthcare should be striving towards that end. Now, realistically, you know, each of us has our own skills, our own interests, our own talents. And not everyone's going to be a master at communication. Not everyone's going to master, active listening and being able to convey certain emotion, etc. But this is one of my answer. One response is this is why healthcare is best as a team, because so not any one discipline or not any one person has to somehow master all of this. But if you work in a high functioning team, you can say, hey, I know my strengths and I can, my social worker is really good at this. I kind of suck at that. And, and as a team, as a way of honoring the work of others as your colleagues, but they can help you, you can help them. Again, none of us has to master all of these things. But if we can convince ourselves that our clinic, our team, our service is in that direction, heading that direction, and as a group, we're attending to this stuff. That's a very important answer to your question, is the teamwork implication. Um, Also, I think there's a difference between being a master at communication and being just at least being kind and basic and decent and respectful. I don't think it's asking too much of any clinician, any doctor to be respectful. It may be asking too much of them to be a palliative care specialist and be able to respond to existential distress and deep fears, etc. But respectful, no, that's not asking too much. So that's part on the culture of medicine, on the training of medicine, of training around communication and self-disclosure and our own lives being important in the caregiving reciprocity recipes. All of that needs to find its way into our curriculum. It's coming. It's going to take a while yet. Um, so I feel like I'm forgetting another answer to your question though, but Hmm. Maybe that's it for now. I suppose. Oh, you asked what can you do on your way to make these kind of realities, make these aspirations a reality. Well, you as a student can bring your humanity. Make sure you don't check your kindness, your basic humanity at the door. It can get crowded out of you as you go through training. And increasingly, especially as you move up the ladder of healthcare and gain more sort of power and leverage, I hate to use those words, but at some point, teaching back to folks, even you're attending, it's not too much to say, pull them aside and say, as a student, say, I was watching you in this interaction and it really made me feel X, Y, or Z. How might I do differently? Or is that what you meant to do? Or help me understand. You may be asking too much of you as a student, but over time, you should get comfortable with feeding back to people. And in this way, we should help each other move towards a more perfect kind of practice. Um, and I think that's my full answer to your question. I feel like I'm forgetting something, but maybe that'll do for now.
Okay. Last question. I am currently training to be a psychotherapist and I'm hoping to work within a palliative care context. I was wondering if there's any insight you could share from your experiences with people confronting the end of their life, specifically the fear that can emerge at the end.
Can you read that last phrase again? I missed that.
She's hoping for any insight about your experiences with people dealing with end of life issues, confronting the end of their life, specifically the fear that can emerge at the end.
Okay, well, great. Well, wonderful. Welcome. I think I'm so glad to hear of anyone going to palliative care, especially psychotherapists. I mean, I think so much of the work we do is really psychotherapy in nature. Um, I don't know that there's a more important piece of our training. So anyway, congratulations, welcome, thank you. Um, in terms of specifically about managing or handling, dealing with fear that comes up almost inevitably in people who are dying or people who are confronting death one way or another, whether as a person, as a patient, or as a caregiver. Fear is very common. So part of my answer to your question would be just to realize, to normalize that fear. It's not a weakness or a failing, and it's outside of, fear is generally outside of our control. And mortal fear is as primal a fear as exists. We are wired to run away from our death. We have social constructs on top of that neurological underpinning that push us away from this subject. We as a species are inherently kind of freaked out by death. So normalizing is so much of the work. And then from there, you can kind of work with it. You can say, okay, so fear is going to be part of the mix. And I would push you to get more specific. What are they afraid of? So probing, go into this fear. This is not a fear to avoid. This is a fear to lean into. Mortal fear, existential fear is a meaningful place. We should all find a way to it. It's a rich place. So go into it. tell me more. What is it that you're afraid of? What do you picture? Is it a thought? Is it, and very often the answer to these questions comes down to either people are afraid of the dying process because we imagine it to be painful and difficult, or we're afraid of the hereafter. We're afraid of obliteration. We're afraid of what comes next, whether it's a judgment day or nothingness or who knows what, purgatories of any kind. So I have found that the mortal fear can generally be broken down to the fear of dying or the fear of being dead. And those open up very different conversations. So pushing to get specific. If it's fear of dying, well, there's a lot of reassurance. Hospice, palliative care can do great work. Pain is not you don't have to be suffering at the end of life. There's a lot that can be done with support and medications. Fear of death, of being dead, well, that's a fear I don't have answers to, but I can pull my chair up next to you and share that fear, and we can look into that abyss together. So accompaniment more becomes the mode very often, an exploration and reframing that fear, working with that fear. What is it trying to tell you? What's that fear trying to tell you? Very often that fear is trying to tell us what we care about, what we what we love or what we hope for. So anyway, there's a quick sort of primer on what to do with fear towards the end of life. I hope that registers.
Okay, great. We're all set. Thanks again, BJ.
All right. Thank you. Bye, guys.